everyone. My name is Lakshmi, and I'm a digital imaging specialist at the Innova Health System. We are based out of the Central Laboratory in Fairfax, Virginia. A little bit background of who we are. We are a non-profit healthcare system based in Northern Virginia. The biggest healthcare system in Northern Virginia, a group of 5 hospitals with more than 16,000 employees and 1,700 licensed beds. The Central Laboratories AP division started the IHC service and the digital pathology service, or the whole slide imaging service, in August 2011. This initiative was mainly started to reduce costs associated with using reference laboratories. And the IHC service, since it began in April 2011, we have been getting a lot of positive feedback. It has greatly improved our turnaround times for specimen diagnosis, and it's actually helping the clinicians, affect a patient care plan quickly. The whole slide imaging service, or the digital pathology service, is also being utilized to support a number of research and clinical applications. The first clinical application that we went ahead was IHC quantification in breast cancer predictive markers, which is the topic of today's presentation, and also it's also helping pathologists who are actually remotely there to discuss pathology diagnosis, and it's also being used to support a number of research applications for the Center for Liver Diseases and so on and so forth. Just a few disclosure statements. We use Aperio scanners and Aperio software for our imaging services, and also we are also developing our in-house image analysis algorithms. We use Ventana and DACO reagents and instruments for IHC. Just a brief overview of what we're going to talk today. I'm just going to introduce the concept of validation very briefly. We're going to talk about whole slide imaging, and then we're going to go into the IHC validation, and then talk about image analysis in detail. Just introduce why do we need validation. We need validation to demonstrate that a test system works in the manner in which it was intended. I think the key word here is the intended purpose. So your validation study design should always state the purpose it was intended for, and also to demonstrate that the new test which you are placing into service demonstrate well as the existing clinical assays. Before we talk about any system validation, I think there are some basic rules here. Most of you might be aware of these system validations, which are called the IQ, OQ, PQ protocols, which means the IQ is the installation qualification, which means that have all the components being installed correctly. For example, when we're talking about an imaging system, how is your cable connection? How is your scan scope stage? How is your autoloader functioning? Is your workstation operational? Is your monitor functional? And so on and so forth. So basically all those installation components have to be checked. And the second one is your operational qualification. Are you able to scan the slide at all the available magnifications over there? How is your tissue finding able to detect the tissue on the slide? And so forth. And then you come up to the performance qualification is you check for your system performance standards. How is your system performing? Are you able to scan slides at your desired magnifications? And how is the quality of the slide? And all these validation have to be documented and be approved by your laboratory medical director. For any study, there are some statistical considerations that we need to take into consideration, and even for these whole slide imaging systems, we have some basic statistical considerations that we had taken into account, just establishing accuracy and the precision studies. Accuracy is how close your measured values are to a true value. For example, how close is your digital read to a light microscopy? How well is the pathologist able to diagnose a digital image versus a manual glass slide read? And accuracy it's a combination of your sensitivity and specificity. Sensitivity is your percentage of positive test results when you're evaluating true positives, and specificity is your true negative, your negative results when you're evaluating your true negatives. And precision studies, I think these are most important when we're talking about whole slide imaging, because you want to characterize the reproducibility of the test system. Just a slide that is scanned today is exactly the same when you scan it, within the same day at a different time and between different days. Again, it's performed by repetitive testing of the same sample. Three main considerations here when we're talking about imaging systems: intra-run, inter-run, and inter-instruments. Intra-run is the same slide scanned at different time points within the same day. Inter-run is slide scan on different days, and inter-instrument is if you have more than one system in your laboratory, then how does the scanning compare between different instruments. And there are some statistical parameters like standard deviations and coefficient of variations that need to be established. And these acceptability expectations have to be established by your laboratory's director. That's a brief introduction on validation. I'm going to talk about whole slide imaging now. It's called digital pathology or e-pathology, precision healthcare, digital imaging. There are a number of terms to it. To keep it short, it is the technology that enables the conversion of glass slides into digital format. And with this technology, there are a number of advantages. It helps us reduce laboratory costs. It eliminates the need to ship glass slides around. You can get it's available instantaneously on the web, so the pathologist can actually read and diagnose off of a computer screen. So it helps improve operational efficiencies and also enhance productivity. You don't have to be looking for your glass slides. It's very easy to retrieve off the database. And also, image analysis actually helps generates quantitative information that that we can use to develop companion diagnostics, and we can actually implement a more personalized healthcare plan. And there are also so there are two qualifications that we thought were important to qualifying this system before we place into clinical utility. The first factor we considered was the proof of consistency studies, and the second one was how good is your digital readout when compared to your conventional microscopy. As we know, conventional microscopy is still the gold standard, and glass is still the gold standard as of today. Hopefully that will change in the future. So when jump right into proof of consistency. So three things that we considered here are intra-run, intra-system. So we scan this slides in the scan scope at different times on the day. I think we used a total of 30 slides with a total of 12 scans over a period of 5 days here. So we had a total of 360 slides images that we actually validated. And then we only have one scan scope system in-house, so the inter-system run was not performed. And since we were actually doing our breast predictive marker validation, we used ER, PR, and HER2 slides for our validation study. And what are the parameters that we measured? We actually measured the percentage of cells that's stained and also the H-score. And for all these 360 slides, the same tumor regions were used, provided by a single pathologist, because we want to eliminate the variations that were introduced by a pathologist. This is just some sample data of of different slides. So we had data from 360 slides, as I mentioned before. So we had the percentage of positive nuclei, or the percentage of cells that were staining with each day, and we had the standard deviations. And we also compare the intensity values within each day between inter-day and intra-run. So as you can see, just an example of a few of the data points here. D1 is data day 1, D2S1 is day 2 scan 1, day 2 scan 2, and so on. And we have had some pretty good numbers, with standard deviation was always less than 2 for all these 360 slides between inter-day and intraday. So the second most important thing was to compare your conventional microscopy versus digital readout. Again, here we are trying to compare how good is your digital readout when compared to the glass slide. So we had utilized 30 slides for each marker, so 30 slides for ER, 30 slides for PR, and 30 slides for HER2. And we utilized 3 pathologists for this study. So the pathologists were actually reading the slides manually, giving off a score. And then there was a washout period of 3 weeks between both the reads, and then pathologists were reading the same slides and issuing the score. This was also actually validating their skill on how well they could diagnose using an image. So, and once we determined them to be qualified, we use the same pathologists in our future image analysis studies. And again, what are the parameters that we measured here? Since we were talking about breast predictive markers, we used the same criteria. We used percentage cells stained and overall intensity score. And our expectation was results of the interpretation of the digital images are as accurate as the interpretation of your manual slide. But again, your acceptability deviations have to be set forth by the medical director. CAP, the college also had some recommendations for validating whole slide imaging systems for primary diagnosis. I don't think there was any formal announcement, or they were not included in the checklist, and these statements actually came off after we had validated our imaging system. But the good news was that most of these were actually in line with what we did to validate our imaging system before we placed it in clinical service. There were 14 statements that were issued from the work group. I'm going to discuss some of the most important ones. They say that validation for each clinical application is necessary because different types of specimens have different capabilities. So they talk you have to validate your frozen sections in a different way rather than you're validating your IHC slides. And then they also say that your entire system must be validated. It's not necessary to validate your each component. Like you don't have to validate your imaging system, computer, monitor, and etc. Everything has to be validated together. And they also talk about pathologist training. Pathologists have to be adequately trained before using the system because they are the ones who are crucial in determining your accuracy studies when compared to the digital readout. And then they also say that they recommend a washout period of at least 2 weeks. For our studies, we used a washout period of greater than 3 weeks. I think the idea was the pathologists would actually forget what they saw on the glass slide when they were actually looking at a digital slide. And the sample set, there are a number of recommendations on the sample set here. So they say minimum is 25, and some people say it's 100. So again, it depends on your laboratory director. And the most important thing is, it's actually important to measure your intra-pathologist reproducibility rather than your diagnostic accuracy. What that means is you have to evaluate, how well is your pathologist able to diagnose from a digital versus manual slide, rather than the diagnostic. Rather than is he diagnosing it correctly or not. That's not important. That's what's important is how well is he diagnosing a manual slide versus a digital image. We'll talk about now IHC validation. Now that we've validated our imaging system, we're going to talk about our IHC validation here. As such, again, there are some general guidelines for any assay, for any test validation. I think the first one comes out as, use your manufacturer's instructions. Know your test materials. Your test materials should be similar to that of your patient samples. And again, you have to provide complete documentation of your results, including your procedure, and your laboratory director must approve these results before you place it into clinical service. When we are talking about analytical validation, there are 2 types of tests. It's qualitative versus quantitative. Qualitative tests are pretty easy. There are actually bimodal tests because it's either positive or negative or high or low. Examples, gram stains and mucin stains. But if the amount of analyte is relevant to your interpretation, then the test is considered as quantitative. And qualitative and quantitative tests have different validation procedures. Now we are talking about breast predictive markers. All these are quantitative tests. So there are, a different set of parameters that we need to take into consideration: your accuracy, your precision, your linearity. Linearity is your direct relationship between the analyte concentration and the test quantity. I'm going to talk about, since we introduced the concept of quantitative testing, I'm going to talk about breast markers. As we all know, ER, estrogen, and progesterone receptor status are assessed on all invasive breast carcinomas because they determine patients' eligibility for hormonal therapy. The HER2 is also tested in patients in invasive carcinomas because it's amplified in about 20% of the breast cancers, and it's actually directly related to clinical outcomes. And again, the concept is here is similar. Start with your manufacturer's instructions. Begin with an FDA-approved antibody and a detection system. Optimize your protocols before you actually start validating your assay. And then if there are any deviations from your validation procedure, like if you're using fixatives other than formalin, and then you have to validate them separately. There are some new concepts that are coming up when we're talking about breast predictive markers, which the CAP calls them as tolerance limits. And these tolerance limits must be documented for each of these antibodies. It simply means that what should and what should not stain with the antibody, and what actually represents an unacceptable result. These tolerance limits must be established when you are doing your validation study, and also after when you are actually put your test into clinical service. They should be a part of your QC procedures. This is actually from the CAP recommendations for validating IHC assays. They talk about how the different methods that you can use for validating your hormone receptor assays. I think the most common one is testing performed in the same blocks in different laboratory that has validated its assay against clinical outcomes. So your reference laboratory can be your another laboratory that have validated its assay against clinical outcome. And the take-home message here is you have to establish 90% agreement in the positive category and 95% agreement for the negative category. That is 90% sensitivity and 95%. For an FDA-approved assay, the laboratory should test at least 20 positives and 20 negative specimens. And of these positive cases, at least 5 of them should be weakly positive. I think these weakly positive specimens actually determine your analytical sensitivity. So it's actually very important to include those specimens in your validation. And they also talk about, less than 10 specimens should be tested in any single run with multiple personnel. If you're using an LDT, which is a laboratory developed test or a laboratory modified test, then laboratory should actually compare results of at least 40 positives and 40 negatives. And again, of these 40, at least 10 should be weakly positive, and 20 specimens should be tested in any one run. These assays actually require a more rigorous validation because treatment decisions are based directly on the results, and there are actually separate recommendations for HER2. And CAP also recommends that laboratories that use specialized techniques, that is image analysis, they must use those same techniques in the validation study. As far as HER2 is concerned, the rules are a little bit strict. We have to establish 95% concordance in both the categories, and the sample size could vary anywhere between 25 to 100 samples. And you could actually validate versus IHC versus IHC or IHC versus FISH in another laboratory. And as always, your test conditions and your QC regimen should be the same. As the conditions and the quality management that will be used once you have your assay in clinical service. And again, specimens should be run on multiple days with multiple testing personnel whenever possible. Just a brief overview of how we obtained our samples. We obtained samples that were previously tested for ER, PR, and HER2. Since we had a consortium of 5 hospitals, all those blocks were brought in, and they were initially screened by an IHC specialist for the quality of the specimen. And one section, and a section was cut and H&E was prepared, and our medical director screened the H&Es and excluded cases with limited material because we did not want to exhaust the patient's specimen in case they come back for further testing. And that's how we obtained our final list of validation, and the IHC slides were stained with multiple personnel. No more than 20 specimens were tested in each run, and the protocols were optimized before we went on with validation. We ended up having a total of 381 cases 169 cases for ER, 160 cases for PR, and 52 cases for HER2. We used an FDA-approved antibody for HER2, so the requirement was 40, so we were way above that. We validated with 52 cases, and that was only in the positive and the negative category. The 2+ category was a separate. I think there were around 15 cases in the 2+ category that were not included as a part of this list. And we did 3 staining runs for the precision studies. They were performed with a gap of at least 1 week. Since we had a large sample set, we decided to have a gap of at least 1 week between runs. These are just some of the examples of our stains. I just put some examples of highly positive and negative stains for each of these markers. And again, this is our precision study. This is a HER2 slide between the 3 runs. So how we evaluated our precision study, the pathologist actually went and scored highlighted regions on the digital image for the first run. And again, our imaging department actually transferred those regions on subsequent runs, run 2 and run 3, and then we analyzed them using our algorithms, and then that's how we determined our assays precision. The most important one for these assays, for these predictive marker assays, are our controls. So external controls and internal controls must be present for each of these assays. External controls help ensure that all the reagents are dispensed properly and the assay is performing as expected. And the internal controls for ER and PR are your lobular elements, which must be positive for ER and PR, and they must be HER2 negative. So these same principles have been used in our validations procedure and are also now a part of our QC procedure after we have gone live. Apart from the internal and the external controls, we also have batch controls, that cover intermediate reactivity, or controls that actually cover a spectrum of expressions. Now, this is not just a high-low, but they cover a spectrum of expressions from 0, 1+, 2+, and 3+. Cell line controls could be used. Some of them actually are a part of the kits, like DACO has the PharmDX kit, and Ventana or the HER2 kit. They're all part of the cell line controls, are all part of these kits. And these batch controls are helpful to calibrate our assay sensitivity, and also they actually show the dynamic range of staining for each run. We score these batch controls daily using image analysis. There are some other cool controls that can be used in place of cell line controls. There are our endometrial tissues, or the myometrial tissues, and normal breast. Normal breast is actually a very good useful control because your stromal cells and your myoepithelial cells should be negative. So based on our experience, we recommend that whenever possible, normal breast tissue from the patient should be submitted as an ER control. These are some of the examples just of the controls. As you can see here, this is an ER negative slide, but your internal lobular elements are actually positive, and your on-slide external control is positive, but the slide itself is negative. This actually shows that your assay is actually working. This is a HER2 negative slide again, but your control is positive, so it shows that your assay is actually working. These are some of the cool controls that we also use apart from our internal and external controls. We use normal breast and also the myometrial tissues. As you can see, the stromal and the myoepithelial layer is actually negative, whereas the lobular elements and stuff are positive for normal breast. And also the normal breast, you also see the dynamic range of staining there. Nothing is like entirely positive or entirely negative. You see the dynamic range of expression in normal breast. And this is myometrial tissue, which is actually positive for ER. And HER2 cell line controls, these are actually a part of the kit. So you can see different, the negative, the 1+, 2+, and the 3+ level of staining here. We're also trying to shift from the normal breast and the myometrial tissues to ER, PR cell line controls as well. And for all these assays, as we know, all the regulations and stuff are based on interpretation. So how do we interpret these assays, these quantitative tests? For ER and PR, the interpretation could be positive, negative, or uninterpretable, and again it depends on your on the amount of analyte that is present. If you have at least 1% of the tumor cells showing positive nuclear staining, they're considered to be positive, and if it's less than 1% of tumor cells showing staining of any intensity, it's considered to be receptor negative. And we have to report all these elements. You have to report if it's positive, negative, the percentage of cells that are staining, and also the intensity of the tumor nuclei. For HER2, again, for HER2, there are a little bit more stringent here. For positive, HER2 requires membrane staining in more than 30% of the tumor cells. Even if you have intense uniform chicken wire pattern in less than 30%, then that's not considered a 3+. That should be qualified as a 2+. And the important point is here the dark chicken wire pattern should be seen in greater than 30% of your tumor cells. A 2+ is actually a complete membrane staining that is non-uniform or weak in intensity, but you see the circumferential distribution in at least 10% of the cells. And again, as I said, although it's very rare, invasive tumors can show intense complete membrane staining in less than 30%. So all these actually qualify as an equivocal category. And negative is no staining or weak or incomplete membrane staining in any portion of the tumor cells. So that's up with our assay validation. I'm going to talk about now how our validation incorporated with image analysis. There is a lot of new terminology in the CAP checklist related to image analysis, digital image analysis. They talk about calibration, which I think is the most important thing that we have to take into consideration. Calibration ensures that the instrument settings yield an appropriate test results. So when we're talking about calibration, we're talking about actually the color and the intensity of the light and the software settings and so on and so forth. And we need to have documentation that the calibration settings yield a correct test results, and also these have to be calibrated periodically for 6 months, or whenever there is a major maintenance for your equipment, or whenever you're using a new reagent lot, or whenever the manufacturer recommends it. And again, there are some other controls also that we need to test every day for these systems. These controls must be tested each day on patient sample testing, and you have to have more than one level. You need to have high, positive, and also intermediate level of controls that we need to test daily. There is also a requirement that these controls be tested by same person as who is testing the patient samples. So this is our design for breast predictive marker validation with image analysis. So the first step was glass slides were actually read by 3 pathologists manually, and they were given a score. And then the same glass slides, after a washout period of at least 3 weeks, were scanned, and the pathologist gave the reading based on a digital digital image, and there were again 3 pathologists. The same 3 pathologists were used. After this washout period, the pathologists had also actually outlined regions for image analysis on the slides, and the algorithms were run on these slides, and then there was an output from the image analysis code. So we had basically 3 different kinds of output. One is the manual read of the glass slides, the second is the digital read, and the third is your image analysis scores. So how close the image analysis scores are to your manual scores determines your accuracy of your algorithm. This was our study design. We had 3 pathologists. The first step was manual scoring for our algorithm development. 3 pathologists scored 20 to 30 slides per marker manually, and they recorded the percentage of tumor cells that were staining and the overall intensity, and also the result. The interpretation is positive or negative or unacceptable. And based off of those manual scores, we went ahead and generated an algorithm, and there are different parameters that we can tune here. I'm going to talk about those in a minute, about the cell feature parameters and the intensity thresholds. So the algorithm was developed based off manual scores from the pathologists for each marker. And then the next step was to actually validate the algorithm setup that was based off of manual scores. So we utilized the pathologists where actually after a washout period of 3 weeks, they again went ahead and scored those slides digitally this time. But they also outlined regions of interest, and they scored each region. They scored the percentage of cells that were stained for each region and also the overall intensity. And the algorithm that was developed in the first step was verified against these regions and then compared with the pathology scores on how well the algorithm performed. And then modifications were done if necessary to be close to the pathologist scoring. And once this is done, the last step was to validate our algorithm performance. So this is actually a blind validation. This is performed by a second user. 10 to 20 slides were used per marker. And then the correlation, we ran the algorithm, and then the correlation was established between the algorithm image analysis scores and the pathology scores. And again, the acceptability limits have to be established by your laboratory director. We used the CAP requirements. We said, for ER/PR, 90% concordance in the positive category, 95% in the negative category, and for HER2, it's 95% in both the categories. And the 3 pathologists that were used for this study were actually skill tested. First, they have to demonstrate manual versus digital concordance, and the cutoff there was 95%, and all our pathologists were 100% concordant between 2 methods. I'm going to talk about some algorithm detail in development features in detail here. Okay, so there are 2 types of parameters that we can tune. Again, there are FDA-approved algorithms also that we could use, so you don't have to go through all this tuning. They're already tuned by the manufacturer, so in those cases, you just have to verify them in 20 positives and 20 negative cases, compare them with your pathology scores, and you're good to go. So for us, we did not use an FDA-approved algorithm, so we had to actually tune all these parameters in-house and develop a validation procedure here. So the first step is, identify the tumor nuclei and separate them from your stromal and other background issues. So there are size and shape thresholds for nuclei that can be adjusted. The minimum nuclear size, the roundness, elongation, compactness, and so forth. That can be adjusted for detection of tumor cells. And the second ones are your intensity thresholds. So what actually classifies a cell as a 1+, as a weak positive, or a strong positive, or a moderately positive. As you can see, intensity goes from 0 to 255, and you have these thresholds at different levels to classify, to actually bin those nuclei into each of these 1+, 2+, or 3+ bins. And again, each biomarker is different, so the algorithms have to be optimized for each cancer and for each biomarker. ER/PR are nuclear stains, so we have a different technique and a different methodology for optimizing these algorithms. And for HER2, it's a membrane stain, so we have a different principles that we used for developing these algorithms. Just shows you on the left is just how increasing 2 parameters, how changes the detection of cells. These are just 2 parameters that are actually used to smoothing. It's actually a smoothing filter that we use. So increasing both these parameters changes the detection of the cells. If you see from the first tile to the last tile here, there is a great deal of change in the cells that were actually detected. And then these are just some examples of ER and PR and HER2, and just a snapshot of our algorithm here. So for HER2, we take into consideration the membrane completeness, because that's what actually determines your which category those staining falls into. And then the second step is your intensity thresholds, where we are talking about here. So if you see the first example here, the first one is actually classified as all are 3+ cells, but changing the thresholds, which go from 0 to 255, you get a totally different output. All these cells are now actually a 2+, and a single one is 3+. The second example again here, it's a 2+ and a 3+ in your first example, but changing your parameters little changes your output there. So it's very important to actually validate these properly. And that's why a pathologist input is essential here to determine the intensity also. And these are just some of the the sample outputs generated. It's your percentage of nuclear cells that are positive, your intensity score, and the number of cells that fall into each bin, and how many of those are actually negative nuclei, how many of them are 2+, and so forth. So the general consensus was on using 3 pathologists for the validation study, and in cases we had discrepancies. We did have discrepancies, especially for the borderline, those weak positive cases. We had discrepancies among the 3 pathologists, so we actually brought in an expert pathologist, a breast pathologist, in case of those discrepancies. And again, it's important to define your cutoffs. Again, they have to be established by the medical director. And your image analysis algorithm, your accuracy actually is defined as degree of closeness of your IA scores to the pathologist scores, and that's how you establish your sensitivity and specificity for these algorithms. And for these assays, again, the reporting elements, there are some guidelines from the college that there are certain elements that have to be included in your image analysis report. Some of them are the patient identification information, the specimen site, type, the physician identification information, and all these have to be on your report. Your pre-analytical specifications, which are your cold ischemic times, the time to fixation, and the time the sample was collected, all these were included as a part of our accession slip. They were not as part of our image analysis report. So this is a sample of the report from our facility. So as you can see, we do have patient identification information, the physician identification information, and the specimen site, if it's a left breast or right breast or what type of specimen was that, and then the procedure that was done, a lumpectomy or a needle core biopsy and so forth. And then once the report was generated, the pathologist, whoever signs off on that report. And the second page of this report contains a whole list of disclaimers and the methodology and the techniques that were used and the interpretation guidelines and so forth. And this is our current workflow. We went live on August the 1st with this, and then this is our workflow. The first step is staining. Once the pathologist sends the request in, staining and scanning is done at the central lab, and then email is sent to the pathologist, or they just wait for the glass to arrive. We have couriers going to the hospitals every hour, so it's a quick turnaround time. And once the slides are scanned, they're available instantaneously on the web. So even before the glass arrives, the pathologist has the image in front of them. The pathologist then goes ahead and outlines the areas for analysis and selects the areas that he wants in the report. So the images that you see in the previous report are actually selected by the pathologist. And it's a very simple step here. That's the only step the pathologist has to do, just outline areas and select areas to be included in the report, which takes, I think, around 2 to 3 minutes, depending on their experience with the system. And then the scoring and report is generated at the central lab. So when they're actually outlining regions, they're just changing the case status. Once they are done, they're just changing the case status to pending image analysis, and then the scoring and report is generated instantaneously at the central lab. And then the report is sent for final review, or via email or copy, or incorporated into our LIS system. So that's a very simple 5-minute workflow for scoring these out. And again, there are some ongoing assessments that we have to consider for these assays. We have to be monitoring all our positive and negative ER rates. And again, these are all recommendations from the college. We have to calculate them at least twice, and they have different parameters. They say your ER negative rate should be less than 30%, and in women older than 65, it should be ER positive, should be more than 80%, and so on. And the pathologist must also be skill tested semi-annually. The pathologists who did not participate in the initial validation, they have to take the skill validation on at least 20 positives and 20 negative specimens. And I think the requirements are they should be 95% correct. So out of 40 specimens, they can only grade less than 2 incorrect assessments. And I think the college also has a proficiency program. I think it's a PM2 program that every laboratory doing this has to take over. And again, 90% correct responses are expected. And unsatisfactory performance will have to revalidate your assay and so on. It's just some pathologist skill validation. Again, acceptance criteria is less than 2 incorrect assessments, and every 6 months you have to verify your validation and calibrate your assay sensitivities and so on. Some of the benefits of this technology: it helps us improve operational efficiency. We have seen this in receiving a lot of positive feedback. Our turnaround time is usually less than 24 hours from the time we receive a request. And also the pathologist can view multiple slides side by side on a single monitor. You can compare the H&E slide versus your ER, PR, and so forth. You can also slide shares with anyone, anywhere in the world, virtual slide sharing for second opinions and so on. And the LIAS integration, which is a phase 2 project, is actually helping the pathologist not to deal with 2 different databases. It's actually, launching the images from your LIAS itself. So that's a phase 2 project. Just the last slide. There are other benefits for this technology in research, in clinical, in education, tumor boards, classroom teaching, and a lot of applications if you want to use this technology for. I thank all our pathologists, our medical director, our lab managers, and our IHC team here for their hard work in this project. And thanks, everyone. If you have any questions, I'm happy to answer.
The first question is, could you please redefine what the washout period is and why it's necessary?
So washout period is actually defined as the time gap between the pathologist reads the manual read versus your digital read. I think it is because I think it's a very important step in your validation procedure because the pathologist is actually the gold standard, and he is the one who is evaluating your digital readout and how close it is in comparison with your manual glass slide. So the pathologist reads the glass slides, and it is highly possible that that pathologists do remember what they see on the glass when they see on the digital slide. So the expectation is during this washout period, it's there so that to eliminate any bias associated between the reads.
Thank you. The next question we have is, what is an H-score?
H-score is actually it's a simple formula. It's actually based off your percentage of cells. It's actually 3 times your percentage of 3+ cells added to 2 times your sum of your 2+ cells and added to plus your percentage of 1+ cells that are staining.
What is the minimal amount of tumor cells in section to quality for imaging or of imaging? I believe it might be, maybe it might be a typo and it's qualify for imaging?
Again, I think for us, for our studies, we said a minimum of 5 regions should be scored per slide. And again, those 5 regions, I think the minimum requirement was at least 300 cells, 300 tumor cells that we considered. And if anything, if less than 300 cells were kind of questionable. If the patient didn't have enough tumor and stuff, then we accepted those. But in cases where we had some good enough tumor, I think the requirement was 5 tumor regions, or at least 300 cells.
Okay. The next
Again,
question.
that was we did. That was we did based on our validation. Again, it depends on your validation procedures and your test materials that you have.
Okay. Thank you. I have another question. How would you validate using a newer technology like the dual ISH that has been FDA cleared? Would you be able to talk on that?
Yes, I think for an FDA-approved assay, I think our recommendation would be using 20 positives and 20 negatives. So I think cases that would be positive would be, I think, amplified, and cases that are unamplified would be a negative. So we would use 20 positives and 20 negatives in both the categories for an FDA approved.
Okay, thank you. Is there any reason to be concerned about the quality of the image viewed if you send the image to another pathologist for consult?
I think that's a good question, and I think there are a number of papers on the color intensity, and depending on your monitor also. But for us, we did not think it was a big issue because we did validate that issue, and it was actually the same when we were actually sending remotely and stuff. So as long as they're using a good quality monitor. So, and there are a number of monitors that are coming up called barcode monitors and so on, which are very expensive to use. But again, it depends on your individual lab.
Okay, thank you. And I think I have the last and final question is how accurate is the digital reading versus the manual reading?
Yes, that's a good question, and I think there are a number of papers within the past year that have published your digital reading versus your manual reading. Again, it depends on the types of specimens, and so your frozen section slides are different from your IHC slides. We validated it for reviewing IHC slides. It could be a different thing for cytology slides and stuff, and it really is a difference. So as far as IHC slides are concerned, I would say it's almost the same.
Okay, and I'm sorry, I did skip one question. Image analysis algorithms, how were they developed? Because you were
are they developed?
You said you were using your own algorithms, and I wanted to know how you were able to develop those, or I believe they just probably want some more information on that.
Yes, there are a lot of FDA-approved algorithms that are ready to use. In those cases, again, you just have to verify that they works for your specimens, your tissue types. But if you're actually trying to do from out of the box, then there are a number of softwares that are actually available for tuning. We use the Perio system for developing our algorithms, and we wrote our own in-house algorithms. And again, as I think I touched base on some of the important factors there are, at least for breast markers, are your cell feature detection parameters. The first step is actually to identify your tumor nuclei, differentiate them from your stromal cells, from your other kinds of cells. And then the second step is actually to bin those nuclei into positive and negative and 2+ and 3+ categories. So those are the two filters that you would use.
Thank you so much. I haven't received any other questions, so I believe that concludes the webinar for today. Once again, thank you so much for supporting the webinar series and taking the time out of your schedule to prepare and present this very informative webinar for us. You have a great day. Thank you, everybody, for participating.